Major support for Carolina Business Review is provided by Grant Thornton. Operating in more than 100 countries, our tax, audit, and advisory professionals specialize in helping companies unlock their growth potential. Novant Health, bringing you world-class technology, clinicians, and care when and where you need it. And Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services with more than 300 operations in 35 countries.
What is the old common sense proverb, better the devil you know than the devil you don't? Well, that's how many people feel about contemporary uncertainty around healthcare versus the future of this country's healthcare. Hello, I'm Chris William, and welcome to the most widely watched and the longest running program on Carolina business and public policy seen across this region for over 25 years. While many find it hard to be sympathetic with large healthcare providers, fact is, hospitals are the first stop and the backstop for virtually all of the population. They take much of the risk in providing sustainable and appropriate care. So how do they feel about the burning issues like a proposed federal plan, like Medicaid, like rural health, mental health, et cetera, et cetera? And where do hospital CEOs see the directional wind blowing on individual healthcare costs? In a moment, the CEOs of Greenville Health, Novant, and New Hanover Regional Medical Center. Please stay with us.
Gratefully acknowledging support by Blue Cross Blue Shield of South Carolina. Please visit us at southcarolinablues.com. The Duke Endowment, a private foundation enriching communities in the Carolinas through higher education, healthcare, rural churches, and children's services. Barings, a leading global asset management firm dedicated to meeting the evolving investment and capital needs of its clients. Learn more at barings.com. On this edition of Carolina Business Review, Dr. Spence Taylor of the Greenville Health System, John Gizdic of the New Hanover Regional Medical Center, and Carl Armato of Novant Health.
Hello, welcome to our program. So we always have the interesting conversations right before the cameras come on and the lights go up. And, you know, so that's where I want to start. Carl, I'll start with you. You know, we were talking about the uncertainty around whatever a new federal health care plan will be. We've had Obamacare now for a while, the ACA. And as we've gone back and forth about the uncertainty, so as a very broad enterprise, clearly stationed in healthcare, how do you model out what healthcare might look like, even in 2017? What do you do?
So, Chris, I'll start with, first of all, I'm excited to be here with you today, and glad to be here with my co-workers here that work across the healthcare industry. So I'll start with the fact that, first of all, Novant Health, we're very concerned about even the new act that is the American Health Care Act. When we think about 23 million people not having the coverage that they need, it's very concerning. And of course, we're worried now with the Affordable Care Act, watching a number of payers drop out of the program, of course, with rising premiums and now additional individuals not having access to care. So the first thing I'll tell you is, so what are we doing about that in this environment? I would tell you the first thing we focused on is really looking at opening up and increasing access for all patients, regardless of their ability to pay, including looking at real aggressive possibilities of reducing healthcare disparities. The other area that we've really stayed focused on is looking at affordability. How do we reduce our healthcare costs, increase quality, and really start to show that we can actually help people in businesses, in individuals, reduce their overall healthcare spending to stay healthy. So really more about wellness, more about prevention, and how do you keep people healthy for a lifetime versus just waiting till individuals get sick. And then the third thing I'll tell you that we're really aggressively looking at is investing in our team members and looking at how do we make sure that our physicians and our nurses who may be facing lots of changes, dealing with burnout, how do we aggressively look at ways of really building the resiliency in physicians and nurses and our team members across Novant Health. So that's been our focus, even with the changing environment with the new act and the new law.
Can you keep that going? Is that down in Greenville Health, out on the coast or in Wilmington? I mean, is that the way to do it? Is that a defensive way to come at it, or is that a progressive offensive?
So, Chris, first of all, thanks for having us as well. This is
course.
going to be a lot of fun. You know, I think it's absolutely the focus we need to do. The uncertainty, you can only control what you can control. And when the IHI came out and said you need to be focused on the triple aim, which is exactly what
What's
Carl
IHI?
said. But the Institute for Healthcare Improvement, and they basically said you need to be focused on cost, you need to be focused on the patient experience, you need to be focused on quality, which if you're in the business world, that's exactly what all businesses are. So in other words, healthcare needs to approach itself as a business, and we have years to catch up with this. Carl said it. I mean, we've had issues around our focus on quality, but the patient experience, the customer satisfaction, we've got lots of opportunity around that. We've got lots of opportunity around access and the challenges we run. And the ideas around this concept of burnout, the administrative burden of physicians. I'm a physician that's been on the job for about a year. The administrative burden that physicians have in their practice has never been as high as it's been. And we have major barriers between the clinicians and the patients. And so there's just lots of opportunity to work on while we await the fate that's going to be handed to us by federal legislation.
Do you see it the same way, John?
Mostly. You know, I believe that moving in this direction is the direction we need to go for healthcare in the United States. I would say, you know, we can't get caught up in all the noise. We have to focus on the factors that we can control, as Carl and Spence were talking about. The point that I'd like to make is one that Spence actually made before we went on the air, which is healthcare is 18% of the GDP.
Mm-hmm. Yeah.
It's not something you can change every 4 years with the president or the political party that is in power at that time and expect to impact that in a positive way. If we think 18% of the GDP is too much, then we need to put the rules in place, make sure we can impact that over the course of time, and those rules can't change every 4 years to make meaningful, long-lasting impact.
Is there any way to take, and I know this, is there any way to take the political hyperbole out of the debate around healthcare, or is that dreaming?
You know, Chris, it's amazing to see how far apart the two parties are, whether you're at the federal level, at the state level. And how the extremes, either to the extreme left or the extreme right, the conversations have been. I would tell you that what we've just talked about, though, improving access, making healthcare affordable, getting at investing in our physicians and our nurses to really look at resiliency. These are things that we ought to all be able to rally behind and find ways to address, regardless of what party you're in.
Why do you think it doesn't happen, though?
Well, I got to tell you, so when I look, for example, when you look just at the Affordable Care Act, there's such different views on whether or not it can survive. I've talked to some that believe, you know, if you make some fixes here, we can continue to operate. Because remember, all of us as operators and as healthcare leaders, we have built a value-based system under the Affordable Care Act. And now we're saying, okay, that's no longer going to work.
The DNA's changed.
And we're going to change it completely. Yeah. So what I'm getting at is we've got to rally behind a model of value that we can all agree on. And I don't know why we can't figure this out, but I have had conversation with a number of senators and a number of our House members to find a way that we could come together and deliver value to people.
These are my words, and I don't want to put words in your mouth, and I don't think I will with any of you, but Spence, so we were talking before the program about how you strategically think about this and go forward. But in your quietest moment, when you're by yourself or you're in your car, you're at your farm or whatever you're doing, what scares you most about the future and even the near term of healthcare? Is it the variability of regulation? Is that what it is? Is it something else? But I mean, really, what deep down just scares you to death?
So. And Carl alluded to it. I mean, let's face it. The government is a major stakeholder. They are our biggest payer. There's no question. Probably 57% of our revenues come from the government. So they'll have a say. They're going to have a say, and we understand that. It's a situation where, and we're a safety net provider. We're going to basically provide the care for the people in Greenville, South Carolina, and we're glad to do it. And you just got to hope for the best. And what we've actually been to our leaders, our senators, and said, we really don't care, we care, but we can adjust to whatever you put into place. What we can't have is, and I think John alluded to it, if it's going to change every 4 years with the presidential election, that's going to be very, very difficult for us to manage. So put a system into place again, it is 18% of the GDP. If you start turning the dials every 4 years, it's going to be difficult for anybody in any part of this industry to adjust and maintain a positive traction forward.
Is it? Go ahead, John.
I was just going to say, I think, when you think about rallying behind a value-based healthcare model, which I think all three of us believe in, and that's the direction we need to move, it is a complete change in the business model for our industry. Going from sick care to health-centric. And that requires significant investment for all of our organizations, a significant mindset shift for our organizations. And to make that investment and sustain that investment, we need a stable set of ground rules and approach in the country and in the state. That's how we're going to be successful, I believe, going forward.
And Chris, John just made a great point, an excellent point. Because think about it, we have made investments to really work to reach people before they need health care in this value-based system. And so all of a sudden you don't start to, you change the whole reimbursement system back to a fee-for-service rule model of some sort. And what we end up with is with people waiting to access health care to when they're actually sick and showing up in the emergency room. So that's really what worries me the most about when you ask the question, what concerns you the most? It's 23 million people not having the coverage they think they need or have and showing up only when they're really sick, versus how do we get wellness and prevention to people ahead of time.
So you've got the federal mandate, you've got those that make federal policy, you've got the states, North and South Carolina, obviously, and you also have this issue about urban versus rural. And now you've got, not new to you, but you're trying to deliver quality health care in rural areas, and on top of it, in places like North Carolina, they are changing the rules about the certificate of need, and can you build, should you build? So logistically, does that make it even harder when the state says, you know what, we're not even going to allow you to build that facility there anymore, and you're thinking, okay, well, how are we going to fulfill our mission? So I guess the question here is, John, we'll stay with North Carolina first, and then Spence, I'd love to hear about the Palmetto State on this. Do the states have your back? Fed's one challenge, but do you feel like you're fighting regulation on two different levels?
There's certainly changes coming at both the state and federal level that are impacting healthcare pretty dramatically, and I think rural healthcare is particularly impacted by some of those changes. CON is a major issue for our rural hospitals, and all of us have rural hospitals as part of our organizations. They are already struggling to stay open and dealing with all these changes. If they were to have organizations come in and cherry pick some of the profitable business that they still have remaining, it's going to, I'm concerned it would drive some of our rural hospitals out of business. And so looking at ways we can partner with rural hospitals, there's been a record amount of consolidation of rural hospitals across both North and South Carolina, and that would continue with the changes we're seeing. We have to leverage technology and telehealth to our rural partners to ensure they're still getting the care they need in the community. But it's particularly difficult for rural providers to make it with all these regulations and changes.
So Chris, just to stay with North Carolina, I would tell you we're not only looking at what's going on at the federal level, but it's obviously at the state level. You mentioned a number of issues. The certificate of need. We're looking at sales tax exemptions for tax exempt and not-for-profit hospitals.
Is that still very alive?
All of those issues are still alive that we're constantly paying attention to. But the other thing, keep in mind, the federal government still influences the majority of the Medicaid dollars that are allocated to a state. And what we're concerned about with the American Health Care Act is they're basing North Carolina's rates based on 2016 rates, which actually North Carolina hospitals actually got together, aggressively worked on improving quality and lowering costs. And now we're going to get actually penalized for lowering the per member per month on the Medicaid population.
And we didn't expand as a state.
And we didn't expand as a state. So when you asked, it's not only the federal side in the state levels that we're looking at, but the federal can influence the allocation to the state for Medicaid purposes.
In South Carolina is very much the same way. There are many of the same issues. The base rate of the Medicaid dollars, big concern. The rural hospitals, major issues around being able to stay open. You know, consolidation is what's happening all over the country, and South Carolina is no exception. And you know, if you look at the Hospital Association and what people trying to do to salvage care in the rural communities of South Carolina. It's a really, really big challenge. And I think it's up to the bigger health systems in our state, at least, to be cognizant of these communities and be able to help alleviate some of their issues and help them to find strategies to manage their populations as well.
Is there any sympathy at all now in the General Assembly or the State House that around this idea that Medicaid accepting federal Medicaid dollars, well, that one's just gone out the window because we don't even know what the corpus of a health care plan is going to look like?
Chris, I think you just nailed it. The last conversations we've had with politicians in the state, it's been really waiting to see what comes out of the federal government before they believe any actions they would take would be really premature at this point.
Yeah, and ideologically, South Carolina has been so conservative that Medicaid expansion has always been an uphill and will continue in the near future, I think, to be a battle if Medicaid expansion is even an option in the new world. And we're just, the conservative nature of this is something we're just going to have to deal with as healthcare providers and manage as we go forward.
You know, go ahead.
I was just saying, we talk about the uncertainty we're facing in the conversations I've had with our state legislators. They're facing uncertainty as well, as Carl alluded to. They're not sure, you know, historically they may have been opposed to Medicaid expansion, but depending on what happens at the federal level, they may need to consider that for North Carolina. And so they're looking for certainty in their budget for the state and what they're trying to deliver to their constituents. And so, you know, we find all of ourselves in this hurry up and wait situation.
Do all of these challenges for rural health centers and the places where people can go to get care, will that end up, if we stay on this track and this arc, will that end up higher morbidity and more mortality rates? Is that the end game?
Oh, it's a great question.
I think, Chris, though, there's a number of things that we've got to address, particularly in the rural settings. I mean, for example, there's things that we could do today to look at how we reimburse for telemedicine that could make a big difference for rural hospitals. For instance, you know, obviously not every rural community can have maybe the 15 specialists that you might need. And so to be able to figure out how maybe some of our centers could get reimbursed for doing telemedicine to all of the rural communities could be really an access point. But that's my point about changing the infrastructure of how we're reimbursed for value-based care to get that kind of model set up.
Yeah, telehealth is very much a value-based proposition because it actually keeps people in their place where they live and manage their health there. But as Carl says, we currently don't get reimbursed for it. So if in telehealth right now, if you actively pursue it in a fee-for-service market or world, as we are right now, that's less revenue that we see. So whether it's our providers, our docs, or our hospitals, so it's a real schizophrenia that we're going through. If you look at GHS, for example, about 32% of our revenues last year were value-based, 2/3 were fee-for-service. So you've got a schizophrenic world, and I think we all probably we're self-insured with our employees. And if you look at our employees, we have 15,000 employees, you know, we eat our home cooking. I mean, if you look at the amount of money we pay, it's about $2.8 million a week in health care provision for our employees, our 15,000 employees and their families. So we see what the business world sees, and we go at risk for that. So that's a big chunk of our value-based. It's a little bit of a test lab that you can do value-based or population health because we have a population, but it's a very schizophrenic world out there.
I think Carl and Spence both hit on a key point. We're talking about rural health care, and we're talking about it from a hospital perspective. We can't deliver care in those rural communities without physicians.
No question.
And these regulations and changes are making it more difficult for physicians to survive in rural areas as well. And then when you look just purely at the availability of physicians, and are they going to pick a rural market versus an urban market? And so that just adds to the difficulties of delivering health care, and that's where telehealth and other technology comes into play. By being able to leverage that, we can provide those services to rural communities. We can't produce enough physicians to have 2 or 3 of them in every market, every specialty that's needed.
So go ahead.
No, what I was going to say is I think Spence hit on something, you know, really important. We at Novant Health have been really working on our own team members to look at, can we reduce the healthcare costs for our own team members that work every day at Novant Health? And what we've watched over the last 3 years, by working with our 500 clinics and our primary care sites to get people at the right place, right time, right price for care, we actually have seen, at the end of 2016, we came in $10 million under the projected costs for our healthcare costs and $2 million under the previous year, which has never happened. So what I'm getting at is we're
You mean
just
for your own employees and team members?
Our own employees and team members. So this is my point, though. We are just getting the infrastructure ready for value-based care to be able to bring that to the marketplace with maybe payers and others to offer to other employers to be able to. How do you really move that and help individuals and employers receive the affordability and the remarkable care that they deserve?
Don't you think, though, Carl, that value-based care will stay around? No matter what happens on the Fed level, eventually it's going to bubble up because it's a good idea.
So the only way, earnestly, the only way you're actually going to bend the cost curve and are going to decrease the cost of care is to quit providing care. And as long as you're in a situation where you're fee-for-service and every time as a vascular surgeon I get paid to blow up a balloon in a superficial femoral artery, I get paid, you're going to blow up balloons in superficial femoral arteries. It's only going to change when we get incented to keep people healthy out of the hospital, out of the emergency rooms, and that's the only way that you're actually going to be able to bend the cost curve to any substantial amount. And I'm like Carl, we have very similar experience. If the per member per month spend on our employees, we're very successful in lowering the cost of our employers because we are at risk for this. And so when we are at risk, you will lower the cost of care and provide good care for our employees, because if our employees aren't healthy, they're not at work. So
we got about 5 minutes left, and I want you all to weigh in on this one. And Spence, you used the term schizophrenic, and it seems a little self-serving, but let's talk about mental health, because mental health didn't have a champion to begin with, and now, Carl, it seems like mental health has been relegated to something that's probably not going to happen. It's not even talked about. Certainly it's needed, but how do hospitals approach this now?
So right now, Chris, what we're doing at Novant Health is we've got a hybrid primary care model that we're introducing, where it's obviously has primary care and behavioral health services mixed together so that we can care for patients right at point of care and not waiting for someone to show up in the emergency room. Unfortunately, if you look at all of our emergency rooms, I've rounded where we've got 50% of our rooms are tied up with behavioral health patients that we can't find beds for, can't find locations for. And so that's part of the issue. We've got to get into the communities upstream and start helping individuals and the people we serve with behavioral health needs. Now, the one thing I want to highlight, though, Chris, I haven't had a chance to talk to John and Spence about this, but I think the future of how we deal with these unmet healthcare needs like behavioral health is the opportunity for big systems like ours to come together and combine resources. And if that means back office consolidation,
Is this shared services, or is this a JV of some sort?
It could be a JV, but it's shared services, the IT investments that we're making, the back office capabilities to come together, I'm pretty confident that there's hundreds of millions of dollars that then we could take as a systems and reallocate to these unmet healthcare needs like behavioral health. Because it's going to take, I don't know if you're going to find new money at the federal level or the state level to address the kind of needs with outpatient services, inpatient services, and the capabilities that we need across our region.
Yeah, I mean, mental health is definitely broke in North Carolina. The reform 15 years ago was well-intentioned, but the community resources were never put in place to handle the volume that was coming from that reform. And so they have ended up in our emergency departments. And Carl's absolutely correct. This is a situation where it has a stigma around it. It does not have the funding it needs to address those issues. And we have to partner with our community. This is a community issue. This cannot only be a hospital issue. This is a community issue.
Totally.
And we have to reach outside of our four walls and partner with other community agencies and really impact mental health. It is not just a certain population. Mental health impacts all of us.
Is it just legislation that's keeping you all from reaching across the aisle, so to speak?
No, I think it's multifactorial. I'd like to say in South Carolina we've got it all figured out, and you guys in North Carolina, we don't have it all figured out. So it's the pervasive nature. It's 1 in 4 patients, 25% of the population, and 70% of folks that have mental illness also have a chronic illness that goes on top of it, and it acts as an amplifier. So meaning people with mental health, when they have diabetes, their diabetes is worse because of their mental health. And so it's totally infiltrated. And what Carl suggested, this idea of a distributive model, instead of a siloed model is absolutely imperative. That's where we've got to get to. And what do we have? If you look at our state agencies and look at, and it's to no fault of anybody, but they're very siloed. You've got people that addiction's different than mental health, which is different than whatever, the hospitals, which is different than inpatient. And the challenge, this is almost an unspeakable challenge that we have, and it is if we don't deal with this, and I don't think we're going to be any new money. I think it's going to be something we're going to have to work with.
Yeah, but Chris, you mentioned the federal regulations and things. I think there is some things. 30 seconds.
Yeah, less.
There are some things that we need to do. We really need to look at laws that have been on the books as they relate to Stark, as they relate to antitrust, and we need to challenge that infrastructure and that model to see if it's going to allow us to do the kinds of things that we just discussed.
You got the first word, you get the last word on that, and that was well wrapped up. Gentlemen, I hope your enthusiasm bubbles through to everyone in the system and just in general to healthcare, because it's infectious, and I think you all have done a great job. Thank you for being on the program.
Thanks
John,
for having us.
Spence,
Thank you,
of course,
Chris.
Carl.
Absolutely. Thank you, Johnny.
Thank you for watching. Until next week, I'm Chris William. Good night.
Major funding for Carolina Business Review was provided by the Duke Endowment, Barings, Grant Thornton, Novant Health, Sunoco, Blue Cross Blue Shield of South Carolina, and by viewers like you. Thank you. Promotional consideration provided by Business North Carolina Magazine. For more information, visit carolinabusinessreview.org.